Welcome back to RhAPPcast, the official podcast of Rheumatology Advanced Practice Providers. I'm your host, Amanda Mixon, here with our guest, Daric Mueller, and this is part 3 of our ACR Psoriatic Arthritis RhAPPup. We've covered some interesting information thus far, and this is the final episode where we will wrap things up. So let's go ahead and dive right in. Daric, talk to me about your last ACR abstract that you found interesting.
For sure. So this is abstract 1470. This is by Zabadi et al. And this is a post-hoc analysis looking at the SPIRIT head-to-head trial, looking at some interesting data from that trial. And as you may know, the SPIRIT head-to-head trial was a large study comparing psoriatic arthritis patients on Ixekizumab to adalimumab. So from this data, basically, the authors were trying to analyze what's the effect of nail disease, nail psoriasis on some of the endpoints in this trial. So essentially, the analysis teased out those people who had nail disease at baseline and those who did not. So essentially, by looking at their NAPSI score, which is a standardized metric for psoriatic nail disease, right? Your pitting, your onycholysis, your crumbling, all of those metrics. So if you had something, you were in the nail group. If you had nothing, you were 0. So took these two groups and assessed multiple disease activity metrics based on which group those patients fell. So that's DAPSA LDA, PASI 90, minimal disease activity or MDA, as well as the SF36. So functionality of physical and mental health. Out of the 565 patients in the SPIRIT head-to-head cohort that they looked at for the post-hoc, they found 386 had nail involvement and 197 did not. So out of those patients, the key takeaways here are those who had nail involvement at baseline actually had numerically greater improvements in their swollen joint counts and their tender joint counts in those various metrics who were on both Ixekizumab and adalimumab versus those who did not have any nail psoriasis. So it seems that there is an augmented response in those with nail disease at baseline. And in those with nail involvement as well, patients who are in the Ixekizumab group versus the adalimumab group had actually numerically higher improvements in overall disease activity metrics. So looking at DAPSA, PASI 90, MDA as early as week 12. So essentially we see more robust changes within swollen joint count and tender joint count in the nail psoriasis patients with whatever agent, but we're seeing almost a more robust response numerically in the Ixekizumab group versus the adalimumab group. So again, more food for thought here. We're looking at a post-hoc data. So we're just gleaming maybe some suggestions. So we know that nail psoriasis, that's a risk factor for development. We tend to see more aggressive disease in those patients, more enthesitis. Nail psoriasis on its own is a nasty part of the disease and is sometimes that holdout manifestation or one of the hardest parts to treat and takes the longest to improve. So I think little bits and pieces, nuggets of information that we can get, even if it's a post-hoc analysis, gives us some info about the therapies that we use. What's your experience in terms of nail disease and these therapeutics?
Yeah, I know. Nail disease is kind of one of those really challenging domains for patients. And I feel like you're right. I mean, part of it is just how long it takes for the nail to grow. But also it's so challenging for the patients and challenging to treat. And this is something that they really, really care about. And that's my experience has been, it's harder to treat. And often, we talked about this on the last episode, but I find that this doesn't surprise me because I do find that our IL-17 agents work better in what I've seen than the TNFs for specifically that nail disease. And again, I think going more towards this idea of this precision, medicine of really targeting the specific cytokines that are more active for psoriatic arthritis, IL-17, 12, 23, those kinds of things. And, again, I totally agree. This is food for thought, right? Because it is a post-hoc analysis, but also further reiterating that, if patients do have nail disease, we probably should be taking that more seriously, that they will be more aggressive, and that we need to consider that when we're thinking about, our treatment choices.
Mm-hmm.
Yeah, so that's an interesting one. All right, well, my last abstract is abstract number 0583. The impact of prior tumor necrosing factor inhibitor treatment and baseline psoriatic arthritis disease activity on minimally clinical important improvement thresholds for efficacy outcomes. So this was also a post-hoc analysis of phase 3 studies of Guselkumab in patients with active psoriatic arthritis. Authors Alexis Ogdi, Philip Meese, and Francis Nanti. So, here we know that psoriatic arthritis and its impacts on patients are commonly assessed using clinical and patient-reported outcomes. So MC2 represents the smallest improvement perceived by patients as clinically meaningful. While MC2 thresholds have been established using observational data, this study aims to determine these thresholds within randomized controlled trial populations, specifically looking at the effects of prior TNF inhibitor treatment and baseline disease activity on these thresholds. So again, we think of a patient that has failed a certain, the more therapies you try, it seems like for a lot of our patients, the more refractory they are, and is it going to be harder to get their disease under control? So data was pooled from 3 phase 3 studies, including 1,400 patients receiving Guselkumab. So we're looking at Discover 1, Discover 2, and Cosmos. Patients are stratified into either biologic naive and TNF experienced cohorts. MC2 thresholds were assessed for various outcomes, including clinical disease activity index for psoriatic arthritis, the psoriatic arthritis disease activity score, patient global assessments for arthritis and psoriasis, patient pain assessment, also our HAQ-DI, and also our FACIT-F. So that's the fatigue score. 3 baseline distribution-based methods were used to determine MC2 thresholds. Achievement of MC2 at week 8 was compared between patients receiving Guselkumab every 8 weeks and those receiving placebo using logistic regression. And additionally, the impacts of baseline psoriatic arthritis disease activity on MC2 thresholds were evaluated by stratifying patients into moderate and high disease activity groups based on those CDAPSA and PASDAS scores. So in terms of the results, the baseline scores, so mean baseline scores indicated high overall psoriatic arthritis disease activity in both TNF experienced and biologic naive cohorts. In terms of the MC2 thresholds, mean MC2 thresholds were generally consistent across cohorts, representing 16 to 39% mean improvement from baseline. At week 8, patients receiving Guselkumab every 8 weeks were significantly more likely to achieve estimated MC2 cutoffs compared to placebo for all outcomes except for the FACIT fatigue in TNF experienced patients, with odds ratios from 1.5 to 3.7. And the baseline disease activity impact, estimated MC2 thresholds were higher in patients with high baseline disease activity compared to those with moderate disease activity, indicating that baseline disease severity influences the magnitude of improvement perceived as clinically meaningful. In terms of the conclusions, so in this pooled RCT population of patients with active psoriatic arthritis, estimated MC2 thresholds were consistent regardless of prior TNF exposure. Patients treated with Guselkumab every 8 weeks were significantly more likely to achieve early MC2 compared to placebo. Higher baseline disease activity was associated with greater MC2 thresholds, suggesting that baseline disease severity does impact the assessment of clinically meaningful improvement. I thought this was really interesting in terms of us looking at this for our patients, really understanding that whether some of our, especially our moderate, patients, whether they have failed a TNF, it seems like they still did really well on Guselkumab. And I think, again, I think this is a theme that we've kind of run into through the ones that we've looked at, but kind of really honing in on certain cytokines being more active, maybe in psoriatic arthritis, that patients that had failed a TNF, it didn't mean that they wouldn't still respond really well to the second line therapy targeting in 23. What do you think?
Yeah, I think we're always worried about our patients when they've been on 1 or 2 or 5 biologics, and we're going down the line. We're always worried what their response is going to be, and I think historically we always think after their first biologic, we're going to lose our bang for our buck for our next one. But I think this potentially informs specifically a population of your patients who've been on TNFs, and you go on to IL-23 blockade, and this suggests that they're having good responses, no matter that they had that prior TNF failure. When a lot of clinical trials are really based on this concept, where if patients have failed multiple TNF inhibitors or multiple other MOAs, you can't even be in the trial. So I think anything that gives us information maybe about these tougher refractory patients is helpful.
Well, and even just looking too at, when we're picking an agent for our patients, one thing that's really nice, in my opinion, about targeting specifically, IL-23 is the safety of it. I mean, it's really nice when I'm having that conversation with patients and I can, there's not much to say when you're talking about the safety, maybe compared to some of our other agents that we're talking to patients about.
Mm-hmm, for sure.
Yeah. So again, something interesting. And, I feel like, again, this is just more data. And there were so many abstracts. I mean, I started kind of going down the rabbit hole of, when we started this to think about what would be interesting and what would be interesting for our listeners. And, I really encourage all of you that are listening to go to the ACR website, really look at some of these abstracts, pick out the ones that you think are interesting, because it really, I feel like the more we learn and the more we read, I feel like it's just going to help us be better clinicians.
Yeah, and looking at ACR abstracts, these are all very snapshots of studies, and I think it's really very informative, and it's actually pretty easy to kind of whisk through a lot of these pretty quickly. So I know I was looking at many abstracts, and also, like Amanda said, having a tough time with picking what I wanted to talk about, because it's all there's so many good nuggets of information here.
Right. And they really do a nice job of kind of like summarizing it so that you can kind of really pick out those key points in a short period of time. Well, again, I hope that you all enjoyed these episodes and found it interesting. We definitely look to do more of this in the future. So that brings us to an end of our ACR Psoriatic Arthritis RhAPPup series. Again, thank you so much, Daric, for joining me and sharing your expertise. We hope this series helped you break down some important information and updates on psoriatic arthritis from this last ACR Convergence and gave you some valuable takeaways for your clinical practice. Daric, is there anything else that you'd like to end with for our listeners?
I don't think I have anything else to add. I'm looking forward to next year's ACR and checking out what's new in 2025.
Me too. Well, if you enjoyed this episode, please be sure to follow us on RhAPPcast so you never miss an episode. And, don't keep it to yourself. Please share this podcast with your friends and colleagues. It's amazing to me how many people listen to this and continue. It just continues to grow, which, again, I'm so honored and privileged to have to be able to be the host of this. You can follow RhAPP on social media for more education, updates, and community discussions. We're on LinkedIn at Rheumatology Advanced Practice Providers, Instagram and X under @RhAPP, as well as Facebook. Thank you again for tuning in, and we will see you next time on RhAPPcast.